Recording has started.
It's great to see everyone, and it's a pleasure to introduce Dr. Brad Thrasher. Dr. Thrasher is sort of keeping his head down right now of his original alma mater, University of Tennessee, because he's had a bit of a rough year so far, but hopefully it'll be looking up. You know, it is basketball season now. After he graduated from University of Tennessee, he went to Blacksburg, Virginia for medical school, and then on to Wake Forest for residency, and then UNC Chapel Hill for Pediatric Endocrinology Fellowship. He joined us. Actually, now we're closing on. Has it been your 2-year anniversary yet? Not quite yet.
Just a little over a year.
Not quite yet.
It feels like 2 years.
It feels like 2 years. So it was the fall of 2018, I think, right?
19.
2019. Sorry, I don't know. Yeah. I'm losing track. I'm trying to forget about 2020.
It was a bad year.
Yes. So his a lot of his work in the past, both educational and research, actually focused on Turner syndrome, and he's done some interesting work, including actually some HPV vaccination work in Turner syndrome, and so sort of apropos for a lot of the vaccine talk we're getting lately with the COVID vaccine. But I'd like to today he is going to be talking to us about Turner syndrome, where we've been, where we're at, and where we're going. Please welcome Dr. Brad Thrasher.
Well, thank you, Dr. Wintergurst, for that very kind introduction, and thank you all for being here virtually in this weird world of 2020, in which we do all this virtually. It's odd sitting in an office talking to myself, but let's do this. If questions come up along the way, please chime in, and we'll go from there. So. I will say that one of the highlights of my fellowship was the research I was involved with Turner syndrome, and I'm kind of excited to share that all with you today, and that'll be kind of at the end of the talk. So moving on and getting going, one disclosure: when I was in fellowship, I did have a grant through the Turner Syndrome Global Alliance. And then this event code today is 1280540 for all of you who need that. I'll pause here for another 2 seconds. All right. And then moving on to the objectives for today. Oh, I'm freezing. Oh, there it goes. Moving on to our objectives. I think it's always good to it gives perspective of where we are in medical care about understanding where we've come from. So we're going to review the history of Turner syndrome for a little bit of time. And then we're going to identify signs and symptoms and potential complications of Turner syndrome. And then we're going to determine what screening should be performed in patients with Turner syndrome. And then lastly, we'll discuss resources and future directions for patients with Turner syndrome. But before we get going, just a little pretest for you all, and you can just keep the answers to yourself. But girls with Turner syndrome can present with which features? A, lymphedema at birth, B, recurrent otitis media, C, delayed puberty, D, difficulty making friends, E, all the above, or F, none of the above. Which is a possible outcome for a patient with Turner syndrome? A, aortic dissection, B, sensorineural hearing loss, C, carry a pregnancy to full term, D, graduate from college, E, all the above, or F, none of the above. And then the last pretest question, patients with Turner syndrome should be screened for which conditions? Nonverbal learning disabilities, scoliosis, celiac disease, hypothyroidism, diabetes, all the above, or none of the above. Perfect. All right, so just keep those answers to yourself, and we'll move on. So as we all know, Turner syndrome is a chromosomal disorder due to complete or partial loss of an X chromosome and is associated with short stature and primary ovarian failure in phenotypic females. The eponym derives from a study published by Dr. Henry Turner describing 7 women with short stature, sexual immaturity, neck webbing, low posterior hairlines, and cubitus valgus. A fun fact of Dr. Turner since I've moved to Louisville is I learned that he actually did his medical school here, and I believe even worked in the radiology department at some point in time, but he made himself famous when he moved to Oklahoma and did his work with these females on Turner syndrome. And Dr. Turner first presented his study in 1938 at a meeting that was known as the Association for the Study of Internal Secretions. So I'm glad we're known as endocrinologists now and not secretionists. But before we had Turner, there was Otto Ehrlich, and he described an 8-year-old girl with short stature, lymphedema of the hands and feet, neck webbing. She had a high arched palate, and she had low set ears. Ehrlich later recognized that his patient and those of Turner's appeared to have the same condition, and he called attention to the work of another scientist named Bonnevie, who described cervical distension and malformation of the ears, face, and limb buds in mice secondary to dissection of subcutaneous fetal tissues by lymph fluid. So Ehrlich suggested that the fetal lymphatic obstruction was causing the net webbing and the other superficial features that was being seen in Turner syndrome, and he proposed the eponym Bonnevie-Ehrlich since they were the first to describe these constellations of anomalies. But that really didn't stick. But Ehrlich's contributions did give rise to the eponym Ehrlich-Turner syndrome, and which is still used in Europe today. But before these other physician scientists, the earliest description of what is believed to be Turner syndrome was given in 1768 by Giovanni Battista Morgagni, who is the father of the scientific theory of medicine. He performed an autopsy of a female who he reported as short, but his words here, but yet much larger than to be classed with the species of dwarfs. And then when he was looking at her gonads, he stated, I looked upon the upper edges of these ligaments to see what kind of testes, gonads, this woman had and had been furnished with, but I looked to no purpose. I very clearly perceived that she had never had any gonads, not even the most obscure beginning of them. So he identified no gonadal tissue in his patient. And then moving forward, it wasn't until 1959 that we understood the root cause of Turner syndrome. With advances in cytogenetics, Dr. Ford discovered that patients with Turner syndrome have one normal X chromosome and a missing or structurally altered second X chromosome. And then if we jump forward 40 years to the year 1978, Dr. Males re-examined Dr. Turner's index patient and found that her karyotype was in fact 45X. And then as cytogenetics has advanced, 50% of individuals are your classic 45X, and the other 50% of individuals with Turner syndrome have mosaicism or structural abnormalities such as a ring X. So even though Dr. Turner wasn't the first to describe Turner syndrome, his name was associated with this syndrome as he was the first to describe multiple patients, emphasized the lack of sexual development due to gonadal failure, and treated patients with exogenous sex steroids and pituitary-derived growth hormone. So that's why we give him credit to this day. So that was kind of our brief history lesson on Turner syndrome. So now we're going to move forward to identifying the signs and symptoms and potential complications of Turner syndrome. So this is kind of, I guess, one of the more meat slides of the presentation, if you will. Because, you know, the diagram that I'm given here is looking at a normal chromosome, a 45XX female, a normal male, and then a female with Turner syndrome. So as we know, in females, we have two X chromosomes, a normal female. One is active and the other is inactivated. In males, we only have one copy of the X chromosome. In Turner syndrome, there's only one copy of the X chromosome. So one would think that having only one copy should not result in a clinical significant phenotype. However, 10 to 15% of genes on the inactivated X chromosome are expressed from both chromosomes. And these include the pseudoautosomal genes, which I've shown on the picture here as the black region at the top of the chromosomes. In males, the Y chromosome contains functionally equivalent homologs in the pseudoautosomal region. And these pseudoautosomal genes are expressed from both chromosomes, and it's these genes that are haploinsufficient in females with Turner syndrome. So it is thought that the loss of these genes are responsible for the Turner syndrome phenotype. And this picture is just kind of going over a lot of the phenotypic features that we see in Turner syndrome. Turner syndrome may be suspected in infancy if we have classic features present during childhood when stature is significantly stunted, or during the teenage years when puberty is delayed. It is important to point out that the diagnosis of Turner syndrome is based on karyotype and not phenotypic features. This slide, again, is just summarizing the typical but highly variable phenotypic features of Turner syndrome reported from a practice in North Carolina. More than 99% of females have short stature, and then the etiology of the short stature is likely a result of skeletal dysplasia, estrogen deficiency, and then a growth hormone secretory dysfunction. They're not growth hormone deficient, though. I think that's important to point out. Other abnormalities, 40% of patients can have kyphosis. High arched palate is commonly seen in females with Turner syndrome, and this can contribute to feeding difficulties in infants. Other relative common skeletal abnormalities include retrognathia, a little over 50% of females have that, cubitus valgus, short fourth metacarpals, and pectus excavatum. Less commonly, patients may exhibit the Madelung deformity of the wrist and a drumstick appearance of the distal phalanges. This picture here was a girl, just a picture off the internet of a girl who exhibits many signs of Turner syndrome. If you kind of look at the frontal view there, you know, she has a thin upper lip. You can see her webbed neck. This is generally more of a cosmetic concern than anything else, but it can affect some of the clothes that females wear just because the collars of the clothes can be difficult. And then on the side view, you can see that she has the retrognathia, she has the low posterior hairline, and the hairs kind of has that sweeping upwards pattern to it. Her ears too, if you look at those, they're a little more low set and posteriorly rotated. So just kind of all common features that we see in Turner syndrome. So here's a little infant diagnosed with Turner syndrome. And we can see that she has the webbed neck. So, and it's very common to in infants to see lymphedema or swelling, I should say, of the hands and feet. It's present in almost all patients diagnosed in the newborn period. The lymphedema does tend to improve with age. However, it remains in about a third of girls. It resolves in about a third. But it also, the ones that does resolve in, about a third of those have a reoccurrence of the lymphedema. And the lymphedema, as the female gets older, may cause thickening of the skin, which can make sometimes wearing shoes and walking uncomfortable. And it also increases the risk of local infections as we get older. This picture here is just kind of showing nail dysplasia, and this is thought to be due secondary from the lymphedema. Causing developmental abnormalities of the nail bed. So the nails tend to be more small, narrow, hypoconvex, and kind of deeply inserted at an acute angle there at the nail bed. Ingrown toenails are fairly common in females with Turner syndrome, especially if the nails are just not trimmed straight across. There's a feet picture here, and I made a little note to myself that feet are relatively large compared to height in females with Turner syndrome, and the feet can even grow more in the females that are on growth hormone therapy. This next picture is just kind of showing the short fourth metacarpal. This is thought to be due to the haploinsufficiency of SHOX, the short stature homeobox gene. Now, fourth short metacarpals can also be seen in other conditions, as well. It's not just linked to Turner syndrome, but if you ever have a short female on exam, you see this pink Turner syndrome. This slide is just showing a female with cubitus valgus, which again occurs in approximately half of females with Turner syndrome. So remember, cubitus valgus is just the angle between the upper arm and the lower arm is greater than 15 degrees. If you kind of look at this girl too, you can see that she has a severe pectus. Her nipples appear to be inverted. There's no breast development, and she has kind of a mild shield chest. So if you're seeing these on physical exam, again, think Turner syndrome. So kind of moving on to the cardiac findings. Cardiovascular disease presents the most serious health problem for women with Turner syndrome and substantially contributes to the increased mortality rates for affected individuals. The morbidity and mortality are due to increased risk for cardiovascular malformations compounded by hypertension and renal abnormalities. Primarily, those risks lead to aortic dissection and dilatation. The prevalence of cardiovascular malformations in patients with Turner syndrome varies across studies and depends on whether a diagnosis is made with either an echocardiogram or a cardiac MRI. Cardiac MRI is generally more sensitive than echocardiograms for detecting the cardiovascular defects, especially valvular disease. Some of the more common malformations encountered in females with Turner syndrome are kind of listed here on the slide, but I think it's important to note that up to 50% of females with Turner syndrome can have any cardiac malformation. Kind of some of the buzzwords on the PEDS boards: coarct of the aorta is commonly seen. Bicuspid aorta valve is actually the most commonly seen in Turner syndrome. We can also have arrhythmias associated with Turner syndrome. We can see VSDs, ASDs, kind of just the work. So just the cardiac findings are significant in these individuals. And on top of the cardiac findings, we also have some congenital malformations of the renal and urinary system, and these are present up to 30 to 40% of patients with Turner syndrome. The more common abnormalities include collecting system malformations, about 20%, positional abnormalities, and then we have horseshoe kidneys, which occur in about 10% of females with Turner syndrome. And then moving on to kind of nonverbal learning disabilities, I think it's important to note that intelligence in females with Turner syndrome is normal, but there may be an increased rate of certain neuropsychological problems in girls and women with Turner syndrome. These include deficits in social cognition, difficulty with nonverbal skills, problem-solving tasks such as mathematics, psychomotor deficits such as clumsiness, and problems with kind of visual spatial organization, which may cause problems, when trying to drive cars and find your way around a city that you don't know. There's also increased risk of attention deficit disorder and problems with executive functioning in females with Turner syndrome. However, though, the verbal skills of patients with Turner syndrome tend to be very strong. The mean verbal IQ of girls with Turner syndrome are very similar to those without Turner syndrome. One study showed that if we just looked at IQ, the verbal IQs, girls with Turner syndrome tested at 101 and the control group tested at 104, so pretty much spot on there. However, there is a significant difference in the performance IQ subscores. The mean performance IQ subscore in females with Turner syndrome was 89 in the study, and when they compared that to the control group, it remained at 104. So this discrepancy at 12 points between the verbal and the performance IQ scores in women with Turner syndrome suggests that there is likely a nonverbal subtype of learning disability. The magnitude of the verbal performance IQ discrepancy does not correlate, though, with age or karyotype. So moving on to kind of some pubertal gonadal findings. So primary hypogonadism is one of the most common features of Turner syndrome, and Turner syndrome is one of the most common causes of premature ovarian failure. Most affected women have no breast development, and have primary amenorrhea. Approximately 15 to 30% of women with Turner syndrome either have initial breast development followed by pubertal arrest, or complete puberty but then develop secondary amenorrhea. A small percentage of women do have normal puberty development and go on to have regular menstruation. However, these individuals typically have milder phenotypes. They tend to be mosaics and not just your classic 45X. There was a retrospective study done several years ago which looked at 276 adults that were proven to have Turner syndrome, and there were 5 women who did have spontaneous puberty and even a spontaneous pregnancy who were found to be 45X. So even in our classic Turner syndromes, the puberty can be completed. I think it's important to know that the ovaries in Turner syndrome are characteristically consistent of small amounts of just connective tissue with no follicles or only a few amounts of atretic follicles. It's interesting if you look at Turner syndrome babies when they're in utero, their follicles are actually developing kind of normal and they look okay. It's just after birth something happens to the gonad, I should say to the ovary, that we get these kind of streak gonads. So we just kind of lose all those follicles and just fills up with connective tissue. And this is one of the biggest reasons, that we see these females in Turner syndrome, or in endocrine clinic, I should say, is to help with growth and then help with puberty development. And then kind of lastly on the slide, it's when we have the mosaics that have Y chromosome material present, the studies do show that they're at risk for gonadoblastomas moving forward, or into the future, I should say. So the diagnosis of Turner syndrome, so a lot of it's based on our clinical suspension, short stature, common ear infections with a webbed neck, the lymphedema, the other features. But even though we can suspect it clinically, to get the diagnosis, we have to get a karyotype to confirm it. And then prompt diagnosis is important because it helps with the management of the comorbidities that are associated with Turner syndrome, and also helps with effective treatment of short stature. So in 2017 was when kind of the most recent consensus guidelines on Turner syndrome were released, and they kind of looked at kind of 5 big areas to address. One was just kind of diagnostic and genetic issues, and then the second was kind of just growth and development during childhood and adolescence. The third was congenital and acquired cardiovascular diseases, and then the fourth was the transition and adult care, and then 5, it was just kind of a wastebasket of just kind of other comorbidities and neurocognitive issues to kind of put everything else in with. So we've talked kind of about puberty, we've talked about cardiovascular diseases, so now we're going to spend a little bit of time looking at growth, because as I alluded to earlier, one of the big reasons we see these females in our clinic is just to help out with growth. So as a whole, girls with Turner syndrome are not growth hormone deficient, and when we give them growth hormone, we actually give them supraphysiologic doses of growth hormone to drive growth. Short stature, as shown in the previous slides, is likely the single most common physical finding in Turner syndrome, with untreated individuals achieving an average adult stature of 20 centimeters or 8 inches shorter that of their peers. So that has them coming in about 4'6" or 4'8" at the end of the day. The absent pubertal growth spurts definitely results in a marked height deficit relative peers during adolescence. And what I mean by that is that a 13-year-old who's an average girl, or excuse me, a 13-year-old average girl with Turner syndrome is the same height as that of an 8.5-year-old female. And there's about an 11-inch or 28 centimeter difference at that age compared to her peers. So growth hormone, we give it to drive growth, and we've learned that the earlier we give it, the more growth we can achieve. And typically girls can get 4 inches if we can start growth hormone. And again, we're about to show you a study that just shows the earlier the better. And then, so these are the factors that kind of go over our growth. But The earlier we start it, the more growth we're going to get. The higher the dose of growth hormone, the better effect. And then in females who aren't getting the growth that we hope, sometimes we'll add in oxandrolone, which is an anabolic hormone, to drive growth, which sometimes can help. Studies show that they can get about another 5 centimeters, let's say 3 to 5 centimeters, when using oxandrolone. So this study was done in 2007 by Dr. Marcia Davenport. And basically, she was just looking at when is the most effective time to start growth hormone. This study was referred to as the toddler study. And as you can tell, the girls that were started at an earlier age definitely outgrew their control groups by quite a bit. Before this time, females with Turner syndrome, we kind of just arbitrarily picked an age, kind of, around 7 or 8 to start growth hormone. But she made the argument if a toddler is showing signs of growth failure, they would likely benefit from growth, which she was able to prove. So growth hormone is now considered standard of care in all females with Turner syndrome who have linear growth failure. As again, they're not growth hormone deficient, but we give the super physiologic doses to kind of drive growth. The first randomized trial that looked at growth hormone therapy in girls with Turner syndrome was done in 2005, and it was done in Canada. And they looked at girls from the ages of 7 to 13, and they kind of randomized them, those that got growth hormone and those that didn't. And they chose a dose of 42 milligrams per kilogram per day, or no treatment at all. And then estrogen replacement was started in all females at 13 years, and then kind of followed until final adult height, or their growth velocity was 2 centimeters a year or less. And the girls in the treatment arm, they received quite a bit more growth, or excuse me, they were on growth hormone for about 5.5 years and grew 7.2 centimeters more than those who were not in the treatment arm. Some other studies too, looking at growth hormone, have looked at when is the best time to start puberty replacement, estradiol, with the thought being that the longer we wait, these kids might grow more. But studies have actually showed that adding estradiol, kind of that normal puberty timing around age 12 at low doses, can have an additive effect and make these individuals a little more taller as well. So it's recommended to not hold puberty or estradiol to a later time point, but to start it around the 12-year-old time frame. Growth hormone is expensive. It can range $10,000 to $40,000 a year. Here in the States, it's much cheaper in other countries, but this is an expensive therapy that we do for our patients. So we've already kind of talked about ovarian insufficiency, so I'm going to move on from that one. Or that was just kind of showing the street gonads and all that kind of stuff. And then this slide here is just kind of looking at going through the girls with the kind of just who will start in puberty, who will have menses and whatnot. I mentioned earlier the one study of the 45X females that have had pregnancy. That's very rare, but it has been reported, and going to develop puberty. But typically the females who start in puberty are mosaics and do have a kind of a milder phenotype of Turner syndrome, if you will. And then kind of a more recent marker in the last decade or so to kind of look for ovarian failure is getting an AMH level, with a level being less than 8 picomole per liter being highly sensitive for predicting ovarian failure. So when we induce puberty in these females, we start around the age of 11 to 12, and our goal is to start at low doses and then just kind to increase naturally as we do physiologically. So we use patches, and we have the females cut patches, and they wear it for a week, and then they're off for the rest of the month, and then we just gradually work our way up over the course of 2 years. Progestin, we add that in typically when the dose gets to around 37.5 mics of the estrogen patch, or at 2 years, if we've been on estrogen for 2 years, or if we're starting to have some breakthrough bleeding, just to kind of help everyone out. And so this is just pointing, this picture here is just pointing to a small estrogen patch on the belly, and that the estrogen patch is just worn continuously in these females. And then, like I said, we add in the progesterone down the road just so that we can have the females cycling regularly so they know kind of when their period's going to come, and not allow just too much buildup to occur in the endometrium, or excuse me, the uterine lining. And then typically, depending on whose protocol you're reading, some people will say use progesterone for 10 days, others will say 12 days. Most papers are anywhere from 10 to 14 days, either 100 to 200 mics of progesterone, and then once it's stopped, you'll have a period a few days later. And so looking at kind of the neurocognitive aspects of Turner syndrome, we've kind of talked a little bit about this already, but I think it's important, or we have these conversations with our families that, talk with your school so that your child can be tested for any type of learning disabilities, so that they're present, they can have, extra time to do tests, tutoring, whatever they need so that they can thrive in life. And challenges can arrive at different phases in life. Some kids do well in elementary and middle school and then start struggling in high school. Some can make it all through secondary education and then really struggle when they get to college. So, sometimes seeing a developmental pediatrician, a psychologist, a therapist can help with some of these issues. These guidelines here, I've kind of just copied and pasted from the 2017 guidelines. And there's not a lot of big differences here. One of the big differences was like with hearing screening, it should now be done every 3 years versus every 1 to 3 years. When it comes to cardiac screening, MRI is recommended, but if anesthesia is going to be required for the patient, just do an echo and then get the cardiac MRI when the patient is able to not be sedated for the procedure. And then regarding a cardiac standpoint, the current guidelines state to get repeat imaging every 5 years in childhood, 10 years in adulthood, and if they're an adult who's wanting to get pregnant, to repeat imaging studies before the patient is trying to conceive. And then looking at all the other ones, this is kind of just very kind of standard of care. A lot of the females can have the refractory Aries strabismus, so once they turn 12 to 18 months of age, just get in with an ophthalmologist, be seen every year. From a dentist standpoint, once we're a year old, just start following annually with a dentist to make sure that our teeth erupt as they should and we don't have any problems there. I mentioned earlier just they're at risk for sensorineural hearing loss. At diagnosis, we get screened, and then every 3 years thereafter. Females with Turner syndrome are at risk for thyroid dysfunction, so it's recommended to get TFTs at diagnosis and then annually thereafter. From a GI standpoint, the females are at risk for celiac disease, so we recommend getting a celiac panel diagnosis and then every 2 to 3 years thereafter, or unless we're having signs or symptoms of celiac disease. At 10 years of age, it's recommended just to get liver enzymes because these females tend to be at risk for more transaminitis as compared to the general population. From a metabolic standpoint, these individuals tend to have a higher risk of type 2 compared to the population just because they're more overweight. So the new guidelines recommend getting an A1C at 10 and a fasting plasma glucose just to kind of get a baseline, and then always counsel on healthy lifestyle habits. At diagnosis, we talked about this earlier, just from a kidney standpoint, we want to get an ultrasound to see do we have any structural defects or not. If nothing's there, then nothing further needs to be done. But if we have a problem, then they go off to see our friends in nephrology for further evaluation. Bone health has been a hot topic in females with Turner syndrome. So now the guidelines, recommend getting a vitamin D level around that 9 to 11 year mark, and then every 2 to 3 years, just to make sure that we're optimizing those to try to prevent osteoporosis as they get older. The current guidelines talk about DEXA scans and obtaining a DEXA scan when we kind of finish up that puberty induction, and we're moving on to the adult kind of replacement of estradiol and progesterone. And so, so that's kind of just the quick and dirty of all the current guidelines that have come out. And so looking into the future, and I kind of ran through this last kind of a little fast because I wanted to spend a little more talk on this, the research that I was doing. But looking into the future, people are still analyzing, like, from a growth standpoint, we feel like we know, yes, we know starting earlier does better, but some people are asking the question, should we start estradiol at low doses? Can that help with neurocognitive features? There are studies in Klinefelter syndrome, and patients who are getting testosterone at pre-puberty tend to have improvements there. So could that be a benefit in females with Turner syndrome if we gave them estradiol when they were pre-pubertal? Could that even affect height outcomes? From a bone health standpoint, now that we feel like we're more doing a better job replacing puberty, kind of in the induction of puberty is kind of more physiologic. Is that going to improve osteoporosis as we move forward in the future? And then from a cardiac health standpoint, since we have more rigorous guidelines, with the cardiac MRIs, better procedures, are we going to catch these earlier to have, less poor outcomes as we move forward? Fertility is a really big hot topic too in Turner syndrome, because when they looked at quality of life studies in adult females with Turner syndrome, not being able to have children was one of the most adverse events affecting their quality of life. And so people are starting, 10 years ago it was, should you get pregnant? The answer was no. Now they're starting to readdress that. The guidelines still say it's a very gray area. And you really need to look at the heart defects, that if we have a history of coarc, bicuspid aorta valve, any type of aortic, dilatation, the answer is no, we shouldn't get pregnant. But if we have a healthy heart that can be closely monitored, then proceed with caution. And then I'm going to kind of spend the last little bit of the lecture talking about various factors affecting the immune system of girls with Turner syndrome. Because this is kind of where I spent the highlight of my research and fellowship. So immune aberrations have been reported in females with Turner syndrome, going all the way back to the 80s. And this paper found that there are alterations in T cell and immunoglobulin subsets. And so they had reduced CD4 cells, and their immunoglobulins IgG and IgM were low in this study. So my fellowship research was centered on the following hypothesis: that recurrent otitis media, which a lot of females have with Turner syndrome, reflects an underlying immune deficiency that is due to missing X chromosome genetic material. So to test this hypothesis, the lab that I worked in, we looked to identify genes that may downregulate the immune system in females with Turner syndrome. So to do this, we performed gene expression profiling of Turner syndrome patients of their peripheral blood mononuclear cells, so PBMCs. The heat map on the left of your screen shows the relative expression levels of 10 X-linked genes that were most depressed in females with Turner syndromes and their PBMCs. I placed a box around the gene UTX, which is ubiquitously transcribed tetratricopeptide on chromosome X, as this was a gene that was highest interest to us, and I'll tell you why here in a minute. So we kind of were interested in UTX, but we wanted to confirm that it truly was decreased in females with Turner syndrome. So to do this, we used real-time PCR, which is the picture on the right of your screen, B, to measure the relative expression of UTX in Turner syndrome subjects and controls, which again showed UTX expression of UTX in females with Turner syndrome is decreased. So as I alluded to in the previous slide, we were particularly interested in UTX as this gene is a known epigenetic regulator of development, differentiation, and maintenance of cell fates. Specifically, UTX function is to remove the methyl groups from the 27th lysine on histone 3. So let's take a trip down memory lane and go back to biochemistry and remember how DNA is packaged within our cells. So DNA winds tightly around histones so that a lot of data can be packaged in a very tiny space. So histones contain amino acid residues that can be biochemically modified. And these histone modifications are associated with gene expression or gene silencing. So histone 3H3, the lysine 27, the trimethylation, is actually a repressive modification. So UTX removes the trimethylated and the dimethylated groups at H3K27, which allows for the unwinding of DNA and increases gene transcription. In the last 5 to 10 years or so, research has shown that the unwinding of DNA does have a role in immune function. The second reason we were interested in this gene is that in the 90s, it was found to be an X-linked gene that escapes X inactivation in both mouse and human studies. So why is that important? So if we go back to that slide from a while ago, we're going back to looking at the pseudoautosomal genes. So remember, on a normal female, she has 2 X chromosomes. On the chromosome that's inactivated, 10 to 15% of genes are still being expressed. In Turner syndrome, we've lost those genes, they're not being expressed. So it's the thought that it is the thought that the loss of the genes for the pseudoautosomal region are responsible for the Turner syndrome phenotype. So, and UTX is one of those pseudoautosomal genes. So, to test our hypothesis that UTX is responsible for immunodeficiencies in Turner syndrome, we created a mouse model. We created mice that were deficient of UTX and their T cells. We then infected the mice with a chronic infection, CMV, LCMV A22 to be exact. And this particular strain is known to clear within 1 to 2 months in wild-type mice. The mice were bled weekly, and the viral loads were measured. And what we found is that the UTX T cell deficient mice were immunodeficient. The figure in panel A shows that at day 66, UTX T cell deficient mice still haven't cleared the infection, whereas the wild-type mice cleared the infection within 1 to 2 months as expected. The figure in panel B shows that on day 66 post-infection, UTX T cell deficient mice still have significant viral loads in their tissues compared to wild types. So we learned that our UTX T cell deficient mice have a problem clearing a viral infection. So then that led to the question of why. So to try to answer that question, we looked at T cell subsets that are known to be important in the clearance of chronic viral infections. And we found that T follicular helper cells were reduced in both frequency and absolute value in our UTX T cell deficient mice. And the follicular helper cells, the T follicular helper cells, they're needed for the production of antiviral antibodies. And to look at the follicular helper cells, we use the surface markers PD1 and CXCR5 to identify the TFH cells by flow cytometry. So after we did that experiment, we then looked at the viral antibody expression and found that IgGs were reduced in our UTX T cell deficient mice. So from our mice studies, we drew the following conclusions. UTX T cell deficient mice have decreased expression of TFH cells, which results in reduced antiviral antibodies, thus creating immunodeficiencies and defective clearance of a chronic viral infection. So we moved on from the mice model to wonder, could this be going on in females with Turner syndrome? So the first thing we did was we looked at the TFH cells in Turner syndrome subjects and found that they do have reduced frequency of TFH cells as well. So we've learned that the frequency is reduced, so then we want to see, well, how do they amount to response to a vaccine? So we chose to measure the antiviral vaccine response in these females with Turner syndrome to the HPV vaccine, the human papillomavirus vaccine, because HPV can cause a chronic viral infection. This vaccine was approved for a wide, I guess the ages, the wide range of ages, and then measuring the vaccine response has been well documented in the literature. When we started our study, Gardasil was a 3-dose series. Now it's a 2-dose series, so we were using the 3-dose model. And so basically what we would do, we would recruit females and we would get their blood. I would spin down to the PBMCs. We would inject them. They would come back at 2 months, and then again at 6 months, and then blood was obtained before each vaccine was given. And so this slide here is kind of looking at the results of our blood. So it's a lysis measurements of antibodies to HPV-16 virus-like peptide. So Gardasil is a recombinant 9-valent vaccine that is prepared from the purified virus-like particles, the VLPs, of the major capsids protein of HPV multiple types, 6, 11, 16, 18, 31, 33, 45, 52, and 58. And so I was specifically looking at 16. So in red are the results of the Turner syndrome participants' antiviral antibody response, and in black are the results of females without Turner syndrome's antiviral antibody response. The x-axis shows the time of the blood draws and the vaccine administration. The y-axis is the optical density. The higher the OD, the higher the antibody response. What we found was there was really no significant difference in the humoral response to HPV vaccine between Turner syndrome subjects and age-matched controls. So kind of what we took away from that. So we know that females with Turner syndrome do have a higher incidence of recurrent otitis media. Whether this is due to an underlying immunodeficiency or not, we're going to still say is not known. Even though we didn't find a difference, recurrent otitis, or difference in the response, the immune response, the humoral response in these females, I should say, there still may be an underlying deficiency, and our data may reflect that there's a T follicular helper cell independent immune response early after vaccination. We might have measured our response too soon after vaccine administration, and we might not be evaluating the specific IgG subsets to see the response, because we were looking at total IgG levels. So, regardless, I think this is still, an interesting study that we did. My lab's still back at UNC, and then they've moved on to UCLA now, are still looking at this. So I think there's going to be more to come in the future in these females, in females with Turner syndrome and potential immunodeficiencies. And so family resources and females with Turner syndrome, for any patients that need to know, the Turner Syndrome Global Alliance is a great foundation that I highly recommend. The Turner Syndrome Society does a wonderful job. They have annual Turner Syndrome conferences that patients and families can recommend. So you can give those references to your patients. And then we're at the end of the presentation here because I'm running out of time, but just to wrap up the post-test, it was pretty much all the above to all the questions because Turner syndrome, people living with Turner syndrome can pretty much do anything they want to do. Questions, and then just fun fact here, the butterfly is actually the symbol of girls with Turner syndrome. So a lot of Turner syndrome adults will have butterflies tattooed on them for that reason. So that is it. Thank you for your time and listening, and I will take any questions that you all have.
So, Brad, Steve Winters here, and how are you?
Good, how are you?
So we tried to set up Liesl and I set up a Turner Society site here at UofL, so maybe you can talk with her and see where we are with that. She had 1 or 2 meetings to get the girls together, and, we were thinking of some projects to move forward with like you have, so maybe chat with her about where we were with that. So adult doctors sometimes see Turner syndrome, and one of the controversies is about the bone mass. So because their bones are so small, my understanding is the DEXA scan really doesn't give you, accurate information, and that they may be overdiagnosed with osteoporosis. What's your view of all of that?
Yeah, so I think, DEXA scans and especially growing children is hard. You got to kind of take it into account for height-based and age-based statuses. I think that moving forward, I hope that since we're doing a better job with puberty, inducing it earlier, using patches that have kind of better, we don't have that first pass oh Lord, I'm blanking on the word I want to use right now, but I think we're doing a better job just inducing puberty, which, that's such an important time for kind of bone mass accrual and life that I'm hopeful that moving forward, we're going to see hopefully less osteoporosis because we're doing a better job on the pediatric end, kind of replacing physiologically what the patient needs.
No. So my question then is, when we order a DEXA scan and we get a low bone mass, are we being misled because their bones
Oh,
are so small? And should we be doing quantitative testing or, CT scanning on other
I
types of
see.
fancier DEXA scans?
I see. So yeah, I mean, I think that yeah, to answer your question there, yeah, I think that we might be getting a false result because I mean, as you and I both know, DEXA scans aren't the best scans when it comes to individuals that don't have normal sized bones. So yeah, I mean, I can't say that I know the literature looking at Turner syndrome on DEXA scans there. I do know that when we would talk at UNC about doing DEXA scans at the transition period, all the adult endocrinologists there would just kind of laugh and be like, "This is a waste of time. That it's not giving us really any results that we need." So I do think that your point there is well taken. That is probably not the best test to be doing. Could be another research topic.
Right. Absolutely.
Hi, Dr. Thrasher. This is Lisa Folsom. Steve, nice to see you. Really, really lovely talk. I have two. I don't have any questions because you covered everything, but I have two comments. The first is Steve is absolutely right. We did begin a local chapter of the Turner Syndrome Society resource group here in Louisville, and we're continuing to meet actually virtually through Zoom meetings during the pandemic. So we have a group of ladies with Turner syndrome that are communicating and getting together and talking about issues. So if you do have either parents of patients or patients who would want to be involved, they can get a hold of our group through the Turner Syndrome Society website and become a part and attend our virtual meetings during the pandemic. And then my second comment was related to the bone density question. And when we see children in our endocrine clinic for other bone questions, particularly fractures, and they're smaller, we'll use a calculator to do to do height adjusted bone density. And for my ladies with Turner syndrome, I'll actually use that calculator if they do have significant short stature. So I will try to do a poor man's measurement of that height adjusted measurement to see if truly based on their height, their bone density is still truly low.
Cool. Thank you, Lisa.
Well, okay, if no one has any others, I have one other. So I was supposed to go into otolaryngology, but I didn't.
Okay.
So, but I remember seeing Turner syndrome girls at the ENT program where I was involved, and so their thing about the infection was that their eustachian tubes, just like many of the other facial structures, aren't exactly right, and the eustachian tubes don't drain, and they're more horizontal or something of that sort, and that the predisposition to ear infections could be anatomically or related rather than humorally. Not to negate what you found, but maybe you'd be more interested in pneumonia or some other infection where, where there's not a wrinkle. So my understanding is that they are susceptible to immune diseases. So type 1 diabetes, Hashimoto's thyroiditis, celiac disease, all of those things that you point out. So there must be some connection between all of those genes, not in the B cells, but maybe in the T cells or, immunology that I don't know anything about,
Yeah, no, I mean, your point's well taken, right. I mean, with the otitis media, yeah, it's been, that's the medical, Lord 101, right? It's the eustachian tubes are more horizontal. We don't drain the way we should. We have that buildup, which is there, which, is all in well, but, I guess the leading thought was, could there also be something else contributing to the structural abnormalities as well? Because females with Turner syndrome, if you look at just UTIs, they tend to have more UTIs than a female without Turner syndrome. So yeah, so those infection risks are there. There probably is something there, like you just said, because we have the Hashimoto's and the celiac and the other autoimmune stuff. We've just not, it still eludes us. We've not been able to identify it yet.
Yeah, I think so too. Yeah. And those are the things you screen for in adulthood.
Mm-hmm.
Yeah.
Yes, sir.
Good. Okay. Well, thanks so much.
Yeah, thank you. All right. Well, everybody have a good rest of your day.
Okay, thanks. Have a nice day. Bye now. Thank you.
Bye-bye.